I'm Andrea Salmon. I'm facilitating today's webinar, and Victor McConvey from Parkinsons is here, and I'll read his bio because it's worth reading. It's fabulous. Victor is the Parkinson's clinical nurse consultant and health team manager at Parkinsons Victoria. Do you really want me to say how long you've been a nurse, Victor?
Too long, way too long.
Do you really want me?
Sorry, we've got two things going now. I'll get rid of that. All right. Victor's been a nurse for 25 years and he's worked in the area of neurology for the past 18 years. He's worked in clinical management and service development positions in both Australia and the UK, including establishing the Parkinson's nurse specialist position in Leeds, UK. In his role at Parkinson's Victoria, Victor leads the health team, providing direction.
How long have you been a nurse, Victor?
Sorry, we're getting a bit of feedback, so it's a bit distracting. Victor is involved in a range of projects, including developing the role and profile of the Parkinson's nurse specialist in Australia and participating in the Working Party reviewing clinical and consumer information generated by Parkinson's Vic.
Too long, way too long. It's a big delay.
Yeah.
That's a huge delay.
So can we have some feedback as to whether you're hearing us properly or it's delayed? It might just be something else. I don't know why we'd be hearing it back as a speaker from that computer. Let's see if that's better. Victor's written journal articles, presented at international conferences and received a number of awards and fellowships related to his work with the Parkinson's community. He's currently chair of the health professionals section of the International Movement Disorder Society, and he also chairs the Palliative Care Task Force with the International Movement Disorder Society. So it's great that Victor's been willing to come today and has persevered with these technical problems we've had at the start. Thank you very much for your patience. And I'll hand over to Victor now to lead us through today's topic on Parkinson's and atypical Parkinson's, the care and challenges. And I would just remind everyone to please type in your questions and we will respond to those either at the time or I'll hold them to an appropriate time in the webinar for Victor to respond to. Thank you, Victor.
No problems. Thanks, Andrea. And thank you everyone for persisting with participating in the webinar. And I do apologise for having to cancel earlier on. And I will explain why, because I somehow managed to get pneumonia, which I can't recommend, and end up with a few complications. So I've got a little bit of endotracheal tube damage to my vocal cords. So at times I do sound a little bit like a teenage boy. So it does squeak a little bit and sometimes the voice drops out completely. But it's much, much better than it was a couple of weeks ago, so hopefully we'll be okay. So just moving on, Parkinson's is obviously a condition that most of us who work in healthcare have become familiar with. It's something we've seen, and we might have seen a patient in passing or even treated someone. It's not a new condition. We know it's been around for a long time. So we've got good descriptions of Parkinson's right back to ancient Greeks. But about 200 years ago, we had a significant piece of work done, which was by a physician and a geologist and a political activist called James Parkinson, and he wrote his essay on the shaking palsy. He described it as the shaking palsy or paralysis agentanus in 1817, and this was an observational study. People he saw in the street, sometimes at quite considerable distance, just seeing the way they moved and their gait pattern, but sometimes it was actually at quite close quarters where he'd encourage people to come back to his rooms and actually write descriptions and question people about what they were experiencing. So within that essay, he actually captured the involuntary tremor, the stiffness and slowness of muscles, but also captured symptoms that we now know are part of Parkinson's, such as sadness and constipation, and also loss of sense of smell. And we now know that they are part of the package that is Parkinson's disease. In 1860, it was called Parkinson's disease by a French neurologist called Charcot, and that name has sort of stuck, and so it's remained Parkinson's disease from then on in. Although Classically, whilst it fits the description of disease per the Oxford Dictionary, most patients living with Parkinson's prefer it just to be referred to as Parkinson's rather than a disease. In Australia, it's the second most common neurological condition we do see, with about 83,000 Australians living with Parkinson's. And it's important to remember that 20% of people are diagnosed under the age of 60, and about 10% are diagnosed under the age of 40. So it is a condition we do see in younger people, but the majority of patients are diagnosed at around about 60 to 65 years of age. This is what we commonly see at Parkinson's.
Post-substantia nigra, there is difficulty in correcting posture when suddenly displaced. This man literally falls backwards when he is lightly pushed. In a healthy subject, rapid passive stretching of a muscle is a smooth movement. In the patient, the stretching is interrupted and is called cogwheel. The volitional movements in the patient are definitely slower than those in the healthy subject. When the patient's hand is placed on his leg, a regular tremor develops in his fingers, thumb, and at the wrist. This tremor is likened to pill rolling. As he walks towards us, the steps are short. The gait is somewhat shuffling. The patient turns slowly. And he sits down awkwardly in a lump.
So there's some of those symptoms that we do see in Parkinson's. Obviously, that fellow who was in the clip had Parkinson's for some time and also didn't have the benefits to the current treatments we've got in contemporary medicine. And you'd also notice it was quite old. So certainly we wouldn't examine patients quite like that these days. We'd probably be a little gentler.
A great clip, though.
Absolutely, but it's worthwhile. It's a good historical clip. But what Parkinson's actually is, it's a progressive neurological disease. The progression is linear, so there are no sudden changes. So if your person with Parkinson's suddenly deteriorates, so suddenly stops walking, we need to look for another reason why. That could be an intercurrent illness that's caused a worsening of neurological symptoms, or it could be something as simple as the patient's just missed a dose of medication, so they're off. So we need to do some investigation under any sudden changes. The underlying cause of Parkinson's, like many neurological conditions, is caused by an abnormal buildup of a protein. The protein in Parkinson's is called alpha-synuclein, and that tends to accumulate around dopamine-producing cells, restricting the production of a neurotransmitter called dopamine. Now, we have our biggest concentration of dopamine-producing cells in the basal ganglia in the brain, but it's also really important to understand when we look at some of the other symptoms of Parkinson's, we also see dopamine-producing cells in vascular tissue and also in gut. So we see, again, this alpha-synuclein protein building up around those dopamine-producing cells, affecting their function. So we see a peripheral nervous system effect of Parkinson's as well as a central nervous system effect. There's no known cause for Parkinson's, an idiopathic disease. However, about 5 to 10% of cases, there is a genetic or inherited component, and we've got about 17 different mutations associated with Parkinson's. Some which are more common than others, some which seem to have an association but aren't always pathological or disease-causing. There's no known evidence to say there are environmental triggers in Parkinson's, although there's lots of discussion around exposure to things such as well water, pesticides, petrochemicals. We know that there is one particular toxic agent that will trigger Parkinson's, and that's an agent called MPTP, which was first isolated in a bad batch of heroin used in San Francisco. So if you want some extra sort of reading, Google the case of the frozen addicts, and you'll find really great descriptions in the late 70s, early 80s of a number of heroin addicts who had a rapid onset of severe Parkinson's symptoms that was irreversible, caused by this toxic agent that was actually contaminating their heroin supply. So it's really interesting. From that, we've actually now got a chemical agent that can induce Parkinson's in laboratory animals. Otherwise, there's no known cause of Parkinson's other than those people that we might have genetic disease. So just we can see a picture of someone's brain, and we actually see the basal ganglia within that brain structure. So it's a very deep organ, it's a very primitive organ within the brain. In the top right-hand corner, we can see a couple of cross-sections of midbrain, and we can certainly see some dark pigmentation in one cross-section towards the outer aspect of the slide, but the one that's more sort of in towards the middle of the slide, we can see that pigmentation's washed out, and that means that there's less production of dopamine, which is black in colour when it's produced. In our little histological slide, we can see a donut-like structure, which is a Lewy body. Now, a Lewy body is the defining symptom of Parkinson's disease, and where we can see those Lewy bodies, which is that accumulation of alpha-synuclein within the basal ganglia. We also see Lewy bodies identified in vascular and also gut tissue, but largely we see it concentrated within the basal ganglia. We can identify that this person had Parkinson's disease. And I say had because our true diagnosis of Parkinson's is actually at post-mortem. So up until that point, the diagnosis is a clinical diagnosis, so we strongly suspect it's Parkinson's. It's not confirmed until post-mortem. But it's a condition that we now believe quite strongly with our research indicating that you've probably had Parkinson's for 10 to 15 years prior to getting any motor symptoms. And by the time you actually develop a tremor or some slowness of movement or something that leads you to seek out some sort of medical attention for a concern, you've probably lost over half your body's ability to produce dopamine. So very early symptoms that we'll identify are a diminishing sense of smell, episodes of depression and low mood, evolving constipation, increased problems with bowel elimination, some blood pressure fluctuations, which usually are orthostatic hypotension, so dropping blood pressure when you move from sitting to standing, and REM sleep disturbance. So that's when you get rapid eye movement sleep. Instead of achieving that state of sleepotonia where we don't move, you actually might be acting your dreams out. Particularly interesting premotor symptom, which does persist throughout the course of the illness, and certainly reviews of sleep study data can now, in some studies, suggesting that if you've got persistent adult REM sleep disturbance, you might be 150% more likely to develop Parkinson's a little bit later on. So it certainly is a significant symptom that we're researching. The other quirky aspect of REM sleep disturbance, that because we know it's a persistent symptom in Parkinson's, we also can identify that the movement you achieve during those REM sleep movements is often much better than when you're awake. So you don't have as much impact of Parkinson's symptoms during REM sleep to your movement. Very interesting symptom that we actually are doing lots of work on it. As I mentioned, we've got no diagnostic test for Parkinson's, clinical diagnosis. Misdiagnosis is very, very common. So you can imagine that patient who presents with maybe some stiffening of muscles in their shoulder. They go to see their GP refer to physio. So they say, oh yeah, you've got probably a bit of a frozen shoulder and injury. As we all know, shoulders are easy to actually injure. And you might have a course of physiotherapy right through to orthopaedic surgical reviews before we actually might identify that maybe there's some other neuromuscular changes and it's actually Parkinson's. Diagnosis for the patient is often quite a traumatic event. So often see a long diagnostic phase, we're having lots of tests. You might have been given a few different diagnoses first of all. So your immediate reaction may actually be, oh, at least I know what it is. So in that doctor's room, then he says, you've got Parkinson's, you might feel a little relieved. The physicians who diagnose often have been diagnosing people with significant neuropathology such as motor neuron disease and worse neurological conditions, often a little bit flippant when they say it's Parkinson's because in their world it's an infinitely treatable condition, measurable in decades. So they often, I've heard many patients report to me, said, but he sort of said to me it was only Parkinson's. And what the patient's hearing is, you've got a lifelong incurable neurological disease. What the neurologist is sort of saying, you've got a disease that's mild in its onset and its presentation, slowly progressive and measured and manageable by medications and surgery. So a big disconnect between those two parties. So for us as healthcare professionals, we're the ones that often need to do a lot of that post-diagnosis, picking up the pieces and counselling and helping that person get on with their lives and sort of assimilating to a new, effectively sort of sense of normal. And that's something we hear an awful lot of at our recently diagnosed seminars at Parkinson's Victoria. But the motor symptoms that we do see, now the disease is more common and will affect one side of the body more than the other. So cardinal symptoms that we see are slowness of movement or bradykinesia, tremor in 70% of people with Parkinson's. So 30% of people with Parkinson's will not develop a tremor. They'll have more of a rigid akinetic form of Parkinson's. Rigidity, so that cogwheel and lead pipe rigidity we saw in the video, and those walking changes. In very early Parkinson's, the walking changes are often sort of a diminishing size of step and reduced clearance from ground, and often loss of arm swing on the side of the body most significantly affected. So often, if we're used to looking at the way people walk, you might pick up some very early symptoms of Parkinson's just by seeing those gait changes. And for those of us who work in movement disorders, it's not uncommon for us to be at the supermarket and to be looking at someone walking up the aisle in the supermarket thinking, I wonder if you know that you've got Parkinson's. Clearly, it's also highly inappropriate to then go and accost that person and say, I think you have a problem. But interestingly enough, an anecdote came from a neurologist who was seeing Billy Connolly present at a comedy show and noticed the way he was walking on stage and approached him after the show and sort of said, really, you should seek a neurological opinion. I suspect the way that you're moving around is that you really look like you've got Parkinson's disease. And subsequently that diagnosis was proven. So, but I think most of us as healthcare professionals probably wouldn't take that step. Some additional symptoms that we might see, postural imbalance, so as the larger muscles get affected, we see often a stooped gait or stooped posture start to evolve. So the trapezius gets stiffer. Excuse me. As the leg muscles get a little bit stiffer, we actually see often a bit of flexion in the legs. So someone's sort of shaped like a bit like a question mark. Some people develop some quite stiff muscles and dystonic change. Our facial muscles also get quite stiff, so we see a diminishing expression in the face, so a hyponemia. You've got all these stiff muscles, so just to move around, do your daily activities, it's more energy sort of burning, so you actually are going to get fatigued. So often people who, those normal waves of somnolence that we all experience, so at 2:30 this afternoon we're all actually thinking, I really could do with a bit of a lie down now. Some with Parkinson's, that will be much more marked. So those fatigue, particularly in that early afternoon, is often much more marked. A little bit later on, you might see some fascinating gait and some freezing. That's usually following commencement of medication. And those freezing episodes also correlate with someone getting some mild cognitive impairment, so decreasing ability to manage multiple stimuli and maintain motion at the same time. And micrography is also a significant symptom, particularly this time of year when people are picking up pens to write Christmas cards, and all of a sudden their message in the Christmas cards and even the way they sign their name is completely different than maybe the way it was last year. But it's more than just a physical symptom. We see some significant autonomic and non-motor symptoms. So from an autonomic perspective, we see reduced GI tract motility. Constipation becomes a significant issue. It's a significant issue throughout the course of the illness. Reflux and heartburn, as we see delayed gastric emptying as well. These are really important symptoms to remember because they are not impacted by the drugs used to treat Parkinson's, but they also might directly impact on drug absorption. So someone who's very constipated will have decreased sort of release of contents from the stomach, including medication, and the drugs are mainly taken up in the small intestine. So a delayed on can happen if someone's really, really constipated. So a really important one for us as healthcare professionals to remember. So if someone's complaining their drugs aren't working, we need to ask them the question of how are your bowels working? Increased perspiration, so sort of a hyperhidrosis can actually happen in Parkinson's, often related to medication fluctuations, but a small percentage of patients will just find that they're sitting quietly, comfortably in a temperature sort of well-modulated room, and all of a sudden they're perspiring profusely. It's a complex autonomic symptom to actually manage, and unfortunately is not drug responsive, tends to be one that we need to manage with some practical suggestions. Increased sticky saliva, we produce a bit more saliva in Parkinson's, and because we have stiffened facial muscles, the nature of that saliva becomes much stickier and more mucoid. That reduced sense of smell persists throughout the course of the illness. We produce increased production in oil in the skin and scalp. So hair suddenly becomes greasy, and we start to develop sort of maybe a build-up of skin cells and maybe almost like teenage spots again, right when we're sort of in our mid-60s, which is most unusual. Blood pressure fluctuations, particularly orthostatic hypotension, sit to stand, feel a bit dizzy, and can contribute to falls, particularly in the presence of some postural instability. Bladder problems, which are urgency. So the communication between the detrusor muscles in the bladder and the mituration centre of the brain is interrupted, and often we'll just get one signal from that mituration centre, which is to go and go immediately. No, I might wait till the next ad break in MasterChef. You will never find out who won MasterChef because you had to run to the toilet. Again, can contribute to falls. And erectile and arousal difficulties also occur because you need a level of dopamine for normal intimate activity and sexual function. From a non-motor perspective, those sleep difficulties will persist. That REM sleep disturbance is often quite disturbing for the patient, but often more so for their bed partner. If you can imagine your bed partner sort of having vivid dreams that maybe he's having a fight, so he might be physically punching, you might be on the receiving end of that fist, and particularly contributed to by the drugs we use to treat Parkinson's, which are really fantastic at inducing nightmares and vivid dreams. Not a great combination when you've got those additional sleep movements. Low mood and depression. We know that mood will lower because of that lower level of dopamine in the brain as our brain produces less dopamine, but also you're living with the symptoms of an incurable neurological condition. You're allowed to feel sad. There might be reactive components of that. So a complex one for us to screen for. And when I'm screening for mood, I will screen both when we know the patient is on with their drugs, so just after they've taken their meds, but also when I know they're going to be sort of have a lower level, so maybe 20 minutes or so before they're due to take their next dose. Pain occurs in Parkinson's. It's not a painless disease. So pain might be neurogenic pain, might be musculoskeletal, musculoskeletal pain, or it might be radicular pain, so sharp shooting, spasming type pain. Problems with multitasking. So doing 2 or 3 things at once becomes difficult. So doing a task you might have always done, such as a complex administrative task where you've got to sign things, assimilate paperwork and get them all in the same envelope, might suddenly start to be more complex and difficult to do. Cooking a meal where you've got to time the vegetables and the meat and cooking the gravy might also become really, really difficult because you actually have to think on multiple planes, and you can't do that with people coming in and out of the kitchen. From a motor perspective, talking and walking might become really difficult if you've got Parkinson's. Anxiety, a big problem, so you might feel more anxious with the condition. Drugs can induce impulse control disorder. One group of drugs in particular are dopamine agonists. So you might have seen some press reports about the drug that induced me to become a hypersexual or become a sex maniac, or the drug that made me gamble. We see those same drugs used in restless leg syndrome as well, inducing the same side effect. They seem to sort of stimulate both the uptake of dopamine more effectively to treat the symptoms of Parkinson's, but also stimulate the part of the brain that's responsible for addictive or compulsive behaviours. So some people who might have had a passing interest in so one of my patients had a hobby of building ships in bottles. We realised he had an impulse control disorder when at clinic, every one of us who he saw in clinic that day got a ship in a bottle. And when we spoke to his wife, she sort of said that's all he does now. If he gets up in the morning, takes his meds, goes to his workroom, and that's all he does for the whole day. I've lost him for that whole day. So we had to pull back that drug, and that hobby went back to a much more normal level. That's a relatively harmless one. The patient who gambles or becomes hypersexual is much more difficult to manage. Hallucinations can occur in Parkinson's, and these are now thought to relate to the actual disease. The proximity of the basal ganglia to where we see our visual cortex is very, very close, so we think there might be a crossover between those two organs. People often also report some olfactory hallucinations as well. Again, we see the olfactory bulb significantly impacted by Parkinson's, so there might be sort of again some impact. So that patient who's had Parkinson's for 20 years, who suddenly starts smelling chocolate cake, we really can probably conceive that that's probably an olfactory hallucination. And paranoia and delusions can also occur, often sort of 7 or 8 years into the condition, and they are often persecutory or delusions of marital infidelity. Hallucinations in particular, it's an important symptom. 70% of people with Parkinson's will experience them, not always associated with significant cognitive change either. So just a little clip of a fellow who's experiencing hallucinations.
slow again. No legs on, oh, I noticed that. These things don't last long.
So he described seeing birds. The conversation started relatively normal until we discovered they didn't have legs on them and they were about the size of a turkey. This fellow had actually driven himself to clinic that morning and had noticed these hallucinations over a couple of months becoming more and more frequent. He knew they were hallucinations. He'd read up on, this was in England, he'd read up on the Parkinson's UK website that hallucinations occur. He wasn't particularly concerned about them, but was getting concerned that they were becoming more frequent. So he did raise them in clinic that day, and his description was as we saw filmed. We treated him with a little bit of antipsychotic, and those hallucinations really abated away. So they're ones that we encourage patients to talk about, and also ones that we as health professionals need to be really aware of, because sometimes they're not as innocuous as seeing a bird and something you can assimilate to being sort of not real. They can also be quite realistic and very lifelike. You might be seeing someone in the room with you. I've had patients sort of see people with guns in the rooms, particularly when they've sort of been hearing reports of maybe yet another sort of significant sort of mass casualty gun event in the United States. They suddenly might see someone with a gun in their room and they become quite frightening. So we do need to take them very seriously, but also make sure we're not necessarily associating someone who's seeing things with a patient who's got an evolving dementia. It becomes something we document and we keep an eye on, but don't necessarily give that person that demented sort of label immediately.
Victor, do most of the major hospitals have a Parkinson's clinic?
So Andrew asked if most of the major hospitals have Parkinson's clinics. Unfortunately, the situation is no. We have a number of our key tertiary facilities that will have some movement disorder services, and they will vary from one neurologist who's got a particular interest in Parkinson's disease to a well-organised multidisciplinary team. So physios, OTs, social workers, nurses, all who have got particular interest in Parkinson's sitting alongside of a neurologist. Internationally, we now recognise a multidisciplinary approach is the best way to manage Parkinson's. It's not just a neurologist or a Parkinson's nurse, it's actually a multidisciplinary team. So we want to foster that, but that's a bit patchy as to how you can access that across Victoria and certainly across Australia.
Okay.
But within what we see in movement disorders, we also see people with a differential diagnosis. Now, these are really important for us as healthcare professionals to have a bit of an understanding of, because often these patients have initially been diagnosed as having idiopathic Parkinson's disease, and they might have a review date with their neurologist in 12 months' time or 6 months' time because they're early diagnosis. Yet us as healthcare professionals, what we're seeing significant symptoms that you wouldn't necessarily see in classic Parkinson's disease. So probably the two most common ones that we see are progressive supranuclear palsy and multiple system atrophy. Progressive supranuclear palsy used to be known as Still-Richardson syndrome, and MSA used to be known as Shy-Drager syndrome. These days they are known as MSA or PSP, and they fall under that banner of atypical Parkinson's conditions. Unfortunately, both of them are similar in their trajectory with a prognosis of 4 to 5 years and with significant disability occurring over time. PSP is caused by an aggregation of a tau protein causing neurofibrillary tangles throughout the central nervous system. Cause is not known, is not familial, doesn't usually happen in people under 45, and the prognosis is quite limited. Some characteristic symptoms we'll see on a clip that I'm about to show you, but progressive and rapid rigidity, bradykinesia, dystonia, loss of control of eye gaze, and we see a fixed direction of eye gaze. We see the muscles controlling communication swallow significantly impacted, and so slurring of speech, swallow becomes quite difficult. And we see some personality changes as we think there's an evolving cognition or cognitive impairment occurring. Unfortunately, because of the communication difficulties, assessing cognition becomes almost impossible. So we're making assumptions that these patients have got a probable dementia, but we can often never actually be fully aware of that because the communication is such that we can't assess for it. We see similar communication difficulties in multiple system atrophy as well. We also see an addition of autonomic nervous system failure with lots of postural hypotension, impotence, urinary retention and severe constipation. MSA is caused more by accumulation of alpha-synuclein, so the same protein as Parkinson's, but throughout a number of different structures within the subcortex. So again, both very, very significant and rapidly progressive diseases. They might initially respond to anti-Parkinson's drugs, but this response is not sustained. So they're quite nasty diseases. And because of the communication impact of the symptoms and the potential for the fact that we might also be seeing cognitive change, identifying early is really important. But often once you've re-diagnosed someone, we need to start conversations quite quickly about advanced care planning, because this is the group of patients that might end up with PEG tubes when really they actually might not want a tube because that might prolong life. So we need to get a good handle on what that individual's sense of quality of life is. And these conditions also need a really rapid and comprehensive multidisciplinary approach to managing them. Unfortunately, these conditions are also not recognised widely by our healthcare system. So if you go into emergency with PSP, what typically happens is the triage nurse will Google PSP and we'll get lots of lovely websites on PlayStation Professional. So the added burden comes to the individual living with the condition and their family is often to become that spokesperson, to become sort of saying, no, this is what this disease actually is. And we have got some good resources about these conditions that we often supply and sort of say, look, if you're encountering any healthcare professional, take along a booklet on PSP so you don't have to keep telling your story over and over again. So this is just a clip of someone with PSP. So you can see this fellow's got a fixed eye gaze. So he's not tracking at all as we're moving him up and down. His gait, because of the stiffening of muscle, is a backward-leaning gait and has a significant grip when it does grip someone. Again, you can see that backward-leaning gait causing someone to fall backwards. In this fellow, we can see the fixed direction of gaze, but he's also developed a blepharospasm, so spasming in the muscles around the eyelid, which again is quite common in these conditions. And usually when we're seeing it, we need to be very aware because that spasm can actually make someone effectively functionally blind, so they can no longer see things effectively. And often the way we would treat it is with a little bit of Botox into those muscles that are causing that spasm. And usually Botox would be administered by the neurologist or maybe a rehab physician. We also might see some vascular Parkinsonism in our practice, caused by a sort of reduced vascular flow to the basal ganglia, or maybe even some small strokes. When we see this, it tends to progress in a step-like progression, as we have little vascular events. It tends to be bilateral in its onset as well, so it sort of tends to give itself away. It might respond to some anti-Parkinson's drugs, but that usually doesn't sustain, but also it tends to be quite stable, particularly if we can start to put someone on appropriate blood-thinning agents to reduce their vascular risk. Drug-induced Parkinson's. The most common cohort of drug-induced Parkinson's we see are people who've had major challenges to mental health. So they've been on lots of antipsychotic therapy, particularly over many decades. We know there can be an accumulation of some of these antipsychotic effects that stops production of dopamine in the brain. So we see those extracranial side effects, and one of those is a Parkinsonism type side effect. Sometimes they forget to tell us about their mental health issue. They just sort of say, when they've been to a GP, says, oh, you've got to touch your Parkinson's. That's what they'll tell us, because it's less stigmatised to have a bit of Parkinson's as it is to have a mental health issue. The other evolving group of drug-induced Parkinson's is people who are chronically using methamphetamine. Really challenging group that we're seeing there, because often they've had a habitual use for 3 or 4 years and they start to develop some Parkinsonian symptoms. And we're not quite sure why. Is it similar to the case of the frozen addicts that I mentioned earlier on, where there's a constituent of the drug specifically toxic to dopamine-producing cells, or is it an effect of the drug which we think might cause a large release of dopamine in the brain? Are we prematurely sort of wearing out those dopamine-producing cells and seeing an onset of Parkinson's? What we do see and what we think is that symptoms are reversible. It does tend to respond a little bit to anti-Parkinson's medications, but we're finding it a very difficult cohort of patients to actually track, and a very difficult cohort of patients to manage in clinics when we are seeing them, because often they've got significant addiction problems, and we're finding that when we're introducing some levodopa-based therapy, they're also getting some dopamine dysregulation, which is a seeming addiction to their levodopa-based medication. So we don't have any clinical pathways to manage them at the moment, and we're sort of struggling to actually even get a cohort of these patients to actually work out what's the best way to treat because, as you can imagine, they're a little bit erratic in showing up to clinics as well. Other neurological, such as Huntington's chorea, Creutzfeldt-Jakob, can sometimes initially present as Parkinson's. In fact, I think almost every presentation of spontaneous CJD in Australia has initially been diagnosed as Parkinson's, but has rapidly changed that diagnosis as some other symptoms have actually sort of crept in.
What is that one again?
Creutzfeldt-Jakob disease, so mad cow's disease.
Okay.
So we tend to see variant disease in Australia because I think we've only had about 18 cases in Australia. Most cases are not necessarily related to those risk factors. So if you lived in Britain in the 80s and the 90s and you consume meat products, such as me, that you might have CJD caused by that. Most what we see is variant disease in Australia where you don't have those risk factors and we just see it spontaneously occurring. I always worry that people would never work out if I've got mad cow's disease. People wouldn't pick any difference in my behaviour. So us as healthcare professionals, some things that we should do, take thorough history, take a family history. So if we're seeing a familial disease, it's more likely to be something like Huntington's chorea in Australia. Past medications over a lifetime, recreational drug use, monitor progression. If you're seeing someone who's presenting with rapid accumulation of symptoms or maybe frequent falling, so they keep coming back to ED, or they keep presenting at clinic, or they have a carer who keeps phoning you, sort of says, look, I'm struggling with his symptoms, he keeps falling at home, should be a red flag, but again, listen to your gut feel as well as a clinician, because often we're actually thinking there's something just not quite right.
Payne, come to reception, please. Christine Payne.
So our treatments for idiopathic Parkinson's largely are tablet-based therapies, particularly in early Parkinson's. So we often will focus around trying to replace that dopamine we're no longer producing. The tablets come in a variety of different forms. So Cinemat Matter Parkinson and Stalevo, there might be a long-acting tablet, there might be a shorter-acting tablet lasts for 3 or 4 hours, and there might be a rapid tablet, so often dispersible, you could take as after a bit of a rescue treatment or a kickstart at the beginning of the day. They continue throughout the effectiveness throughout the course of the illness, but because the illness progresses, they don't slow the illness down. We need to continually titrate these drug therapies. So someone who, at the beginning of disease, might take 1 tablet 3 times a day. After 5 years, they might be taking 1 tablet every 3 hours. They might be increasing doses as well as increasing frequency. And the longer you live with Parkinson's, the more important it is to get the medication on time every time. If you're a therapist who's caring for someone with Parkinson's, maybe in a rehab setting, it's really, really important to check with the nurses when you get the patient on the ward, have they had their meds this morning? Please don't try and put someone through some physiotherapy or some therapy without their drugs being on board, because it won't work. The patient won't be able to participate. And the worst thing we can do is say, oh, patients refuse to participate in rehab because they can't, because they're off. And that's because the nurses forgot to give the meds, or you've been really early, you've got your patient on time, but the drug run's been delayed by some incident on the ward, or the patients have got to take their drugs. So we need to always ask that they've had their drugs on time every time, particularly the levodopa-based medication. The most common side effect of this drug is nausea, because when it crosses the blood-brain barrier, it stimulates the vomiting centre in the brain. Something that's often not well understood, particularly by GPs, is that the anti-nausea agents, the common ones you most would probably use, such as Maxilin and Stematol, actually sort of shouldn't be used in Parkinson's because they have the dopamine antagonist effect that block the uptake of dopamine. The only safe anti-nausea agent is Motilium or domperidone. So again, if someone isn't participating in therapy and they said, I've had some nausea, I've taken some Maxilin, it's because the drug stopped, that Maxilin stopped the uptake of the drug. But that symptom effect of that Maxilin stopping the uptake might be persistent for up to 6 weeks, not just the 6 hours we know as the Maxilin half-life. So we need to be really careful about that. And we're often educating patients that if they're having any encounter, particularly with an emergency department, they need to flag that they've got a drug sensitivity to those common anti-nausea agents of Maxilin and Stematol, because ED nurses love using it. Because it's tablet-based therapy, we see fluctuating levels of dopamine throughout the period, so we do see some wearing off. So tablets will work for a period of time, but that level of dopamine we introduce will start to abate, and those symptoms will start to come back. What we want is someone not to wear off too significantly throughout the day, which means we've got to continually titrate drug therapies over time. So once every 6 hours might turn into once every 4 hours, then once every 3 hours, to some people who might be taking hourly medication to get them through the day.
And Victor, would that be largely managed by the neurologist or the GP?
There's two answers to that question. If you're in Melbourne, many GPs will sort of say, oh, you need to talk to your neurologist about managing those drugs. I don't do it. If you're in the country, sometimes country GPs will sort of say, oh, look, it's too hard to get to the neurologist, so I'll manage it.
Yeah.
And so you might have a variety of different outcomes. What we do know with patients is they tend to self-modify medications a little bit. So some patients will add in extra doses between consultations. Some people will change timings of drugs around to see what works for them.
And is that okay?
Ideally, we don't want them to do it too significantly. We want them to get some advice. We will often sort of say to patients when they phone us about, I think I need to take more, we'll sort of say, look, go and have a discussion with your GP. Maybe your GP could put a call into your neurologist, because often doctor-to-doctor conversations will happen more readily than a patient to a neurologist conversation. And it depends on who that patient's actually seeing. And some neurologists will actually say to the patient, absolutely, look, if you feel that you need to take a little bit more, take one or two more, but don't take any more than 3. If you get into that stage, you need to come back and see me, make an emergency appointment. Depends on who you see. And we all work with doctors, and we all know that that's about as easy as herding cats, because they're all completely different in the way they practice. And I know when I worked in theatres years and years ago, we each had cards on doctors about what they would like and how they like to be addressed, to how they like their table set up, how they like their patient draped, all sorts of things. So they're all a bit sort of idiosyncratic. Unfortunately, that's a maze that we'll have to make our way through from time to time. Some other medications we're probably going to use, dopamine agonists. So they stimulate the uptake of dopamine effectively. They tend to come in once a day preparation, so Cifrol extend release, and Nupro, which is a patch. These are also those drugs that I mentioned can cause that dopamine, can cause the impulse control disorder. So we see that those funny behaviours creeping in. So for us as healthcare professionals, if someone's had these added into their regime, just keep an eye on what's actually going on, making sure we're not developing any sort of problems which evolve over time. We might change the way we metabolize dopamine with an MAO-B receptor inhibitor, so it blocks the uptake, blocks the MAO-B in the brain, which otherwise metabolizes dopamine, and a COMT inhibitor will block the COMT enzyme, which otherwise breaks levodopa down. So basically making levodopa last a bit longer. Some anticholinergics are quite commonly used, such as bromocriptine or artane, because they have a mild dopamine agonist effect and can be really useful in tremor-dominant Parkinson's. They're falling a little bit out of favour these days because we're seeing more side effects of them, so dry mouth and dry secretion, and in older adults we need to be quite concerned about confusion because of these drugs, and in some people urinary retention. So we need to keep an eye if someone's on one of these drugs for what's happening, particularly with confusional states. For managing meds, ideally get it on time, and one of the key interventions we can do as healthcare professionals is to actually make sure the patient's got the appropriate supports to get their drugs on time every time. We've helped them program their mobile phone to put a medication alarm on. We've helped them source the medication sort of timer device, might be a pillbox timer or a vibrating watch, or a whole range of different things to help trigger, oh, you need to take your drugs at this particular time. Because I know when I've had to take regular medications, I've usually missed a dose of that antibiotic, which I was supposed to take 4 times a day, or I've missed something. Or I sort of think, oh, well, I'm an hour out with taking my steroids, it doesn't really matter, it's once a day. It becomes more important with Parkinson's to get it on time every time. And particularly with the levodopa-based drugs, often that time factor between on time and not on time can be around about 10 minutes.
Oh, wow.
So we deal with quite sort of narrow therapeutic intervals at times. For patients, I sort of say, ask if you can self-medicate if you're going to hospital. And for people who are control of medication in hospital, sort of say, get the patient to self-medicate and you observe them. How concordant are they? Because research indicates to us that once someone's taking more than three doses of medication or 3 different drugs, they're less likely to be concordant. And that's for any illness. So we need to be really aware of those sorts of things. So helping someone get drugs on time every time is really key. So sometimes this time of year, Christmas present, when I get lots of phone calls about Parkinson's, where can I get a medication timer watch? My dad, it's going to be his Christmas present this year. Which I sort of see, that's a bit like buying your kids a school uniform for a Christmas present. Get someone some fun, and maybe the medication timer device can be for some other time. Increasingly, we're seeing surgery being used as a treatment for Parkinson's. And the surgery is deep brain stimulation surgery. This is the one that the sexy sort of therapy in Parkinson's, the one we often get the most media attention about, because it's quite dramatic when someone goes from an off state to when we turn the stimulators on, they go to an on state. And we're actually trying to stimulate a couple of distinct regions of the brain that are responsible for triggering symptoms. So these regions are a bit dopamine depleted, so they've got some abnormal electrical activity, and introducing stimulation through our probe starts to actually introduce some more normal stimulation, more normal electric activity. That's a bit like a pacemaker type device that's introducing that stimulation. So the timing of our surgery these days is also early disease. We used to say, oh, when we've really got not many drugs to offer you, we might do surgery. Now we're sort of saying, oh, when we're starting to see some early motor fluctuations or some early changes in the impact of those drugs, so you can sort of see, oh, you are wearing off, and you're taking drugs every 4 hourly, so you're wearing off between those drugs at 4 hourly intervals. Oh, we should consider stimulation surgery now. So people are being offered surgery sort of from 2 to 5 years in, which is brought about by a major study called the Early Stim study. So there's lots of articles on early stim about optimal timing of deep brain stimulation surgery. We have most of our major tertiary hospitals will do surgery, DBS programs in Victoria. It's variable throughout Australia as to who does surgery and as to what your public access is. We have a very small public access scheme per year in Victoria, so we do about 14 to 20 cases publicly. Most are done through the private sector. The pathway to surgery, like all things in Parkinson's, is multidisciplinary. So a thorough multidisciplinary assessment of symptoms and the impact of Parkinson's. We do some pre-surgical counselling, because at the end of the day, this is surgery we do largely while the patient's awake. So it's conscious stereotactic surgery. We need to know the person's Parkinson's intimately. We'll do high Tesla MRIs to actually have a really good understanding of brain geography, because the type of the area of the brain we're going to be stimulating are going to be things such as the subthalamic nucleus, or the pedunculain pontine nucleus, or the globus pallidus, so very small regions within that basal ganglia, to actually depend on, and that depends on what we stimulate, depends on the symptoms the patient's exhibiting. So really sort of a high lot of science and a high lot of actually sort of good skill to actually get the stimulator in the right place. When someone's had surgery, there's often an immediate lesioning effect, which means the symptoms often go away almost immediately. That wears off in 3 to 4 weeks. So often have a patient who thinks the surgery's worked, they're euphoric immediately, 3 or 4 weeks later thinking maybe it's not worked so well because the symptoms are starting to come back. And at that 3 to 4 week time, that's when we're going to be starting to finesse the stimulation. So probably getting the stimulation and the medication therapies right probably takes us about 4 to 6 months post-surgery. Again, it's not an immediate sort of thumbs up, we've fixed everything. It does take some time to get everything right, which is complex on the background of a condition that is continuing to progress. So lots of finessing, but it does give us another avenue to treat the symptoms of Parkinson's as they do occur as the condition progresses. So again, a valuable intervention for Parkinson's, particularly for people with younger onset Parkinson's. For a disease that's a bit more advanced, you might use some infusion therapies. The 2 infusion therapies we've got are apomorphine, which is the potent dopamine agonist, causes very effective uptake of dopamine in the brain, but it's given as a subcutaneous either injection intermittently or an infusion, which gives you much smoother uptake of dopamine throughout the day. So it means you have to have a carer who can actually site a needle and who's able enough to actually manage quite a small infusion pump, which whilst not complex, does take a little bit of getting used to. Intrajejunal dopamine or duodopa is the other infusion therapy that we see. It's a little bit more fiddly because the patient requires a small operation. We've got to insert a jejunal tube. So they have a PEG tube popped in with a jejunal extension and then hooked up to a cassette with sort of a gel form of levodopa in it that slowly drip feeds dopamine into the part of the gut that will most readily uptake it. Again, gives you a smooth level of dopamine throughout the day. So very useful at smoothing on and off fluctuations. So a very valuable drug to use. It's available fully on the pharmaceutical benefit scheme. We've probably got about 400 people in Australia on it with an increasing uptake. And with dopamine, we've probably only got around about, I think last count was about 400 people in Australia on it. So they're invasive therapies, they're a bit fiddly, they need good carer support, but they do actually provide good smooth control of symptoms for someone who's had Parkinson's for some time. but obviously they need good carer support.
You wouldn't go on them first up?
No, you would often, many people with Parkinson's would have their symptoms adequately managed throughout their duration of illness over 30 or 40 years just by tablet-based therapy. They may not need these advanced therapies. But because we've got better at treating lots of other things around Parkinson's, people are living much longer, so you're probably going to start to see increasing these advanced therapies uptake as patients live much longer, and when they live with Parkinson's for 30 years or so, they might be in a situation where we really need to smooth them off. These therapies also have significant usefulness in the aged care setting, because if you've got someone who's got complex advanced Parkinson's within a nursing home setting, an infused therapy, whilst initially it might be a bit startling for someone or carers in the aged care setting, does reduce the burden of having to get someone complex medication regimes at very regular intervals, and does often make the patient's quality of life much better. But increasingly, exercise is seen as a treatment for Parkinson's. We've now got good bodies of evidence to sort of say probably the change in the neurochemistry that occurs as a result of exercise is potentially neuroprotective. We think we produce more GDNF within our central nervous system, which has the effect of actually preserving and reducing alpha-synuclein, preserving dopamine producing by dropping that alpha-synuclein. Longitudinal studies of human beings, particularly one big study in Germany, shows that people who participate in regular exercise throughout a week had a much slower progression of illness, and that's been over about 6 years so far. So exercise is something we actually do encourage people with Parkinson's to do, and certainly if it's already early Parkinson's and they've never exercised before, we sort of say actually maybe we need to start an exercise regime. Some of the latest research that's percolated through that I've seen presented in the last couple of months is that we think the dose of exercise might be about an hour a day, 5 days a week. So that's not an insignificant amount of exercise.
It's a fair amount of exercise.
But that combination would be resistance, aerobic and core strength training. So you can mix it up to something that's quite interesting for someone. So it could be a little bit of weightlifting, maybe some Pilates for core strength, and maybe some dancing with Parkinson's or some Tai Chi with Parkinson's, which again is mixing it up. So we're seeing sort of a palette of exercises. And I guess as we move into the brave new world of patient-centred care with My Aged Care and NDIS, we'd like those programs to actually participate in helping support people to exercise more effectively. So as healthcare professionals, we might be actually helping people plan and putting exercise as part of their plans. But just some practical symptom management. Cognitive change in Parkinson's, something that we need to be very, very aware of, and is often present in very early Parkinson's. So on diagnosis, there is a level of cognitive change which we can often detect at neuropsychological assessment. That's usually a bit of bradycardia or some slowed reactions, some slowed thinking. Most commonly presents as things such as maybe some word finding difficulties. We all have word finding difficulties when we're a bit tired, but it's often a bit more apparent in Parkinson's. Usually no impact on functional life, usually able to participate in work and life quite well. No problems early on, but just detectable often with some quite fine assessment. A little bit later on, we might see some more mild cognitive impairment. Usually this will start to impact on some multitasking, so functional independence is starting to be slightly impaired. Shows up with someone who complains they can no longer do things they previously did, things don't seem to be working as well, so we might need to provide some strategies around, okay, plan ahead, check before you complete a task that you've gone through all the right steps, and so a little bit more thinking about it, and also reducing external stimulation that might detract from a task at hand. That might even include just walking. So when someone's walking, you might want to keep them focused. So things such as not walking and talking at the same time, or if we're walking with someone maybe in a therapy environment, making sure that it's not too busy, not too much other noise that might be distracting from that gait. And we might even provide someone with some cues to maintain gait, such as using a metronome or a sound to maintain their cadence of walking. A little bit later on in Parkinson's, in 10 to 15% of people with Parkinson's, they might develop some Parkinson's disease dementia. That's when we see those Lewy bodies starting to ascend from sitting within the basal ganglia to the cerebral cortex, affecting thinking. Lewy body dementia and Parkinson's disease dementia has a distinct pattern of sometimes being Patient's pretty good, then one day they'll be terrible. So it's a very fluctuating pattern. Lewy body dementia, it's a differential diagnosis of Parkinson's disease. If we're seeing someone who has a Parkinson's disease diagnosis, and within 12 months of that diagnosis, we're seeing significant cognitive change, it's a Lewy body disease diagnosis, not a Parkinson's disease diagnosis, and not a Parkinson's disease dementia. It is a different condition. And we sort of say we've got the 1 year rule. So if you've got early cognitive change within 12 months, we should need to re-diagnose as dementia with Lewy bodies, not Parkinson's disease. If you're seeing cognitive change later on in Parkinson's, it's probably a Parkinson's disease dementia. And interesting, when we've looked at brains of people with Parkinson's disease dementia, it's often a mixed pattern of dementia, so there's some Alzheimer's type dementia as well as some Lewy body impact as well. And if we're seeing again early cognitive change, particularly frontotemporal lobe changes, it may well be an atypical Parkinson's condition. And particularly PSP or progressive supranuclear palsy often presents with a frontotemporal lobe dementia as a presenting symptom and then progresses with getting some movement disorder symptoms a bit later on. Hallucinations and delusions, as I mentioned, are common in about 60% of people with Parkinson's. Delusions in about 10% of people with Parkinson's. They're often persecutory delusions or marriage infidelity, and they creep in really silently. And it's often the offhand comment that's suddenly made to maybe one nurse or one therapist about, I'm not going to do it. I'm not taking those drugs from you. You're trying to poison me. And so an accusation gets made, or the patient's wife gets accused of having an affair. This might happen in the home environment. All of a sudden, we had a patient who's hit clinic and there's a bit of a crisis happening because the wife's distressed because he keeps accusing her of having an affair. You try and work through it, and suddenly you get it sort of allocated as, oh, well, that physiotherapist Mark, he's having an affair with my wife because he's supporting her. She's also trying to poison me because she gives me these drugs. The nurses are helping her as well. They all want my money. These things can evolve into complete disasters that lead to family breakdown and lead to really difficult situations in aged care facilities. So if we're starting to hear those funny little comments, we need to raise a flag. May well be we're seeing some delusions starting to impact. We treat them the same as hallucinations with some atypical antipsychotic. And the two drugs of choice are usually Seroquel or clozapine. If we suddenly reach for things such as risperidone or olanzapine, which are commonly ones that we use in aged care, they have an impact of often stopping uptake of dopamine, can worsen the Parkinson's symptoms. So ideally, if we're seeing these things happening, we need to make sure the patient's treating neurologist is aware and that we make sure if we're treating with medications, we've chosen the drugs of choice. Provide lots of care and support to families. Reassure that this will go away. To reassure that it will take some time to resolve, particularly with delusions. So it's not a quick fix as soon as we start taking the medication. And it sometimes might mean that we need to book someone into a respite stay because you've got someone who's accusing your wife of trying to kill him. We might need to actually remove him from that environment until those drugs take effect. And occasionally, on the very rare occasion, we need to actually verify that that's not actually a true accusation. We know that sometimes things do get really fraught. There can be some abuse going on that might be sort of, we need to really verify what's going on. At the end of the day, we have a responsibility for patient safety as well. But I have to say, in most cases in Parkinson's, it's often delusion that's crept in. Communication is a big challenge. With some cognitive linguistic changes, we're already finding difficulties in delayed processing and that multitasking. We can rely less on orofacial or that non-verbal communication because we don't get that non-verbal feedback. We need to establish our environments well for communication, take some time to communicate, allow people some time to actually respond to us. Get people to say things in different ways. It might be that someone sort of says, or we might sort of say yes/no response. So we might ask more questions, get yes/no, to give people time to respond. Don't walk and talk single task. Maybe use some aids and equipment. Particularly valuable for patients in those environments such as maybe EDs. You might want to use a phrase board because you might not have the time to actually sort of see the same nurse over time. And having had a recent interaction with emergency where being there for nearly 48 hours, and over that 48 hours I didn't see the same nurse twice. If that's what EDs are like these days, we really need to give our patients some sort of communication device to communicate, because it takes a while to work out how best to communicate with someone, and if you're not that same person who's seeing the person every time, we need to give them some other tools. Simple tools such as a pacing board, which is our small board down the bottom with the squares on it, where you slow the speech down by moving your finger for every square, for every word that you say, slows and focuses the speech, light riders or electronic communication devices to those phrase boards, which can be valuable. Need to really be prescribed by a speech pathologist ideally. But sometimes we can grab a device if we're a therapist in another space just to help us get through until we can make that speech pathology referral. Continence, urgency, big problem, and can significantly contribute to falls. If the patient gets suddenly gripped with urgency, they forget they need a walking frame, they forget they need to call a nurse to help them get to the toilet, and all of a sudden that overwhelming impulse to get to the toilet has become overwhelming. So some things that we will often do, we use some antimuscarinic agents such as tolterodine can help, but can cause some confusion, so we need to be careful about pelvic floor exercises. They can be valuable for both males and females. They don't take the urgency away, but when you're gripped with urgency, if you can actually think, oh, I need to activate my pelvic floor exercise muscles, they will actually give you more time to get to the toilet and to maybe ask that assistance. Topical estrogen for females can make those exercises a bit easier as well, particularly if they're postmenopausal. Continence aids if someone's getting caught short. And if someone is still in the community, a continence aid might be the public toilet finder application on your smartphone. So if you've been out for a little while and you're anxious, oh, I haven't been to the toilet for a little while, you can hit that magic icon and you can work out where the closest toilet is. Getting people to think ahead, so do go to the toilet before you leave the house. Because if you suddenly get gripped when that muscles get stretched and you get that urgency, it's not going to be as apparent. Be aware that constipation will worsen that sense of urgency as we reduce the space in the pelvic cavity if we've got a full, that sort of lower GI tract. So the second most common cause of hospitalisation is constipation after falls. And if you've ever been in an emergency when someone's presented and they haven't moved their bowels for sort of 7 days, it's not nice for the patient and it's certainly not nice for you. Significant constipation can also contribute to things such as chest infection, as you see the transverse colon so impacted that you might have a raised hemidiaphragm and can't shift as much air. Proactively manage water and walking. Add fibre to your diet. Get people to actually make sure they're being regular, that they're moving their bowels every day. Reassure patients it's okay to take a laxative on a regular basis. Novacol is probably the one we most commonly use in Parkinson's. It's PBS listed. The dose is titratable up and down as per your bowel motion, and it's quite gentle. It's not an irritant, so it doesn't cause spasming, which getting the slow gut to spasm just causes colic. So it's quite a valuable one. But just that reassurance that we want you to stay regular and it's okay to take a laxative on a regular basis is probably a key thing that we can do. Sex. No one ever talks about it, and as health professionals, we rarely assess the impact a disease has had on someone's ability and their sexual relations. We know in Parkinson's there is an impact of that lower level of dopamine, reducing arousal and desire. Relationships change because of illness. And you can get some discordant relationships because sometimes relationships are held together by that bond of that mutual intimacy. Not so much of a mutual intellectual pursuit, but that what they do in the bedroom or elsewhere in having sex is the thing that bonds that relationship. And suddenly someone's got Parkinson's and their desires reduce, the relationship changes. There's erectile dysfunction in males, there's reduced production of vaginal secretions which can cause painful intercourse in females. There's physical changes, so you can't participate as you once used to. Sleep disturbance, that REM sleep disturbance where your bed partner with Parkinson's keeps punching you, you're not going to be in the same bed anymore. You're going to be somewhere else for your own sleep, but also because you don't want to be punched. So that spontaneous intimate activity that happens in the middle of the night just doesn't occur anymore. There can be drug side effects to reduce desire, particularly from antidepressant or antipsychotic therapy. Or you might go the other way. You might have developed some impulse control disorder and hypersexuality, and sometimes some bizarre sexual sort of way things actually played out when you're on those dopamine agonist drugs. If someone presents with some intimate activity, be aware that if you're the therapist that that person's got the best rapport with, even though you're the OT or the physiotherapist or the speech pathologist, they might want to talk to you because they trust you. They feel safe with you. They're not going to talk to their neurologist about sexual problems. Because if you've ever come across a consultant, they're not inviting that discussion, and they're not really ones that you can approach about it. So it's often us, because we have that luxury, spending a bit more time with patients. Listen, if you can't answer the question, get help. Give me a call at Parkinsons Victoria. It's something I've presented on internationally. It's something I've got a particular interest in. Sort of stuff we might do is some relationship counselling, particularly if the relationship has changed. Talk to people about changing the time of your intimate activity. Bedtime at night might be the worst time. You're fatigued from a days of activity and your Parkinson's. You've not taken meds for a while, so you've got more motor symptoms. So it might be harder to initiate and participate in activity. 10 o'clock in the morning might be much better. You've taken your doses, you're refreshed from a night's sleep. Going back to bed can be much better and more satisfying intimate relationship, and you can actually physically participate than maybe last thing of the day. Viagra, Cialis can work for males. Not always. We need to be aware of blood pressure fluctuations and be aware of delayed gastric emptying. That man who's dropped that little magic purple tablet might discover the onset of the effect is an hour and a half later, not that 45 minutes that the pack sort of says it will be. So in that respect, Cialis is slightly better because it tends to have a much better and more predictable effect, but you might need to take it earlier. Because the last thing you want to be is armed and dangerous when everyone else has gone to bed. Or you've taken your Viagra and Cialis and you plan to go back in the morning, nothing's happened, and your wife's gone down the street and all of a sudden you're ready. Splints, rings, pumps, lubricants. Sexyland can be a really great source for some patients. We've taken some of our support groups on little field trips to Sexyland. They're not like the corner dirty bookstore they used to be. They're large, light places. They've got a whole range of different things, as well as some of those things that we might not want to be looking at, like the DVDs, but they've got a whole range of different devices, and often the people that work there can be quite helpful. And they can actually help people think maybe, it doesn't have to be that missionary position, it can be something else. So without us actually having to say it, they can actually do some exploration and they can introduce some other things to their sort of sexual repertoire that actually might be of benefit. And also is assess for hypersexuality. But also assess, is it a problem? For those patients who've developed some problems, what we might want to do is you might want to talk to both of the couples. Is it really a problem? Are they actually currently enjoying that increased level of sexual activity? And if they're sort of saying, actually, no, don't change anything, we're quite enjoying it, as a couple of patients said to me, you just have to keep monitoring. And if it's becoming a problem for either person, that's when we need to raise the flag that drug needs to be reviewed. Falls management, falls occur commonly. Some of the work by Meg Morris, who's one of our Melbourne-based physiotherapists who's done huge amounts of research into Parkinson's, has been able to identify that falls occur often pre-diagnosis at a high rate for someone who's age-matched. And once Parkinson's has been diagnosed, they still continue to occur. Most common triggers for falling are freezing and turning. And contributing to freezing and turning is often that mild cognitive impairment. So you can't manage walking through a doorway, that visual stimulate the doorway and maintain your gait. All of a sudden your feet get stuck to the floor and become frozen. And it's often hard to problem solve to actually work out what to do to get over that freeze. And we might need to provide someone with a strategy to actually get through that. Postural imbalance will alter the centre of gravity, contributes to falling over, particularly when you go from sit to stand. And orthostatic hypotension, so where your blood pressure drops as you move from sitting to standing, will also contribute to falls. Particularly apparent you've got a bit of postural instability, some orthostatic hypotension, and you've got some urinary urgency. So you suddenly leap out of your chair because your bladder's telling you to go to the toilet. You're not standing up straight, so your centre of gravity is upward, and your blood pressure drops and you feel dizzy. This lovely triad of common symptoms we see, and someone's had Parkinson's often for longer than 7 years, can really significantly contribute to falling over. We need to assess for all of them. We need to declutter environments. Consider cueing if freezing is contributing to falls. And cues might be simple as some white lines on the floor to get someone through a doorway. Teaching someone a strategy, okay, when you approach a doorway, you've got to concentrate on big steps. An appropriate gait aid and hip protectors. There might also be some cueing devices available. Maybe it's a laser pointer that attaches to someone's walking stick or walking frame or even to their belt, that if they feel that they're stuck, they can just touch their side and there's actually a laser pointed to the ground. They see that point, they've then got to step towards. This is an example of some basic rehabilitative cueing. We've got this fellow distracted, the request for him to walk out of the door. So his feet have become stuck to the ground. So we're going to provide him with a very simple cue, which is a piece of paper with the instruction of take a step over that cue. He's able to reinitiate his gait. Very, very simple. That can be the piece of paper. It can be us sort of saying 1, 2, 3, take a big step. And for someone, for him at home, we might sort of say, oh, look, we know that you have a problem getting into the bathroom because you've got a very narrow hallway or narrow sort of corner to go around to get to the bathroom. We might put some permanent lines on the floor in those particular spaces. That's a visual reminder that you need to take large steps and to concentrate on taking large steps. And the key to acute working is a patient has to be focused and concentrating on actually responding to that cue. If they're distracted, no matter how many lines you put on the floor, it's not going to work. That cue needs to go with the patient's cognition to thinking, this is what I've got to do now. So when we are screening for things in Parkinson's, some useful devices that we can actually do is there are many screening tools actually available. Using the same screening tool persistently actually helps. And often that might mean the one that you actually are most confident in using. Some things that I find particularly valuable in looking at some of the impact of Parkinson's are some of the motor screening tools we've got. The UPDRS is probably got the most validated one, but it's one we commonly use in research. And it's really comprehensive. So I'd encourage you, Google United Parkinson's Disease Rating Scale, have a look and see what you might do. And sometimes you can just pluck out a section of it to use in your practice, depending on what discipline you're from. But other screening tools such as the Epworth Sleepiness Scale can be really valuable. The Montreal Cognitive Assessment Screen, again, infinitely Googleable, and there are multiple variations of that screen, so you can bypass that learned effect. So we know people can learn the answers to their mini-mental screen really easily. And MoCA's got more evidence to actually support its use in Parkinson's disease than it has the MMSE. MMSE can be a little bit crude. So I want to use the best screening tool. But if you're more familiar with using MMSE, by all means use it. And if you're seeing changes, that needs to be a trigger for maybe us getting someone referred to a neuropsychologist for a thorough cognitive screen, because cognition change in Parkinson's is complex. For mood and depression, I tend to use the Oxford Geriatric Depression Scale, but the Beck Depression Inventory is again got some good evidence behind it. Again, in another really valuable screen, which is actually a patient-focused screen, the patient fills in their questionnaire, is the Motor Movement Disorder Society Non-Motor Symptom Questionnaire. Again, just Google that. You'll come up with a screen which you can print off, and will help detect on some of those other screening tools that are actually part of the problems that are going on. Is the patient hallucinating? Is there a degree of sleep disturbance? A really fantastic, well-validated screening tool as well. Again, ones that can be really often great valuable, get the patient to fill it in their waiting room right before they see you, and gives us some ideas as to where to focus our therapy and what other referrals we might need to make and what red flags we might actually need to be able to identify to other members of the treating team. But throughout a lifetime, care is highly personalised. No two people will ever be the same with their Parkinson's. So it's really personalised care. And treatments and symptoms will vary widely from individual to individual. We need to consider other things, such as other comorbidities and normal ageing, and the impact they have on Parkinson's symptoms. Our most significant challenge is often supporting medication administration concordance. So helping people with devices is really valuable. Listening to patients, listening to family members. They give us this wonderful tapestry of what it's like living with Parkinson's, and they're often the experts. And the worst thing we can do is sort of say, oh no, we know what to do now. No, listen to what they say and And particularly for carers, because sometimes just letting that voice be heard, they will tell you some wonderful things about what's happening, and sometimes the stuff that the patients aren't telling you, because patients are fearful of progression of disease. So they come to us as clinicians and they're on their best behaviour. Sometimes they've even taken more medication, so they're on their best behaviour for you on that particular day. So we're not seeing the real thing. So family members give us this wonderful other sort of illustrated history about what's actually going on. And Parkinson's needs a multidisciplinary approach throughout the course of illness. And particularly as we're getting those advanced stages, the things getting more complex. And as we enter a palliative phase, which is hard to define in Parkinson's disease, again, we need to continue that multidisciplinary approach to promote comfort. And as practitioners, some of the most important work we do is supporting someone's quality of life, listening to that individual about what is quality of life, what's important to them, and us helping to maintain that quality of life. And it might be different to what we might think. It might be different to thinking, oh, we just want to focus on maintaining gait and mobility. Whereas a patient might sort of say, I'm willing to compromise on a few things with my mobility because I actually really want you to address this other symptom that I've got. So listening is really, really important. The palliative needs. Now, as Andrew mentioned, I'm the chair of a palliative care task force. And what's really surprising is that there are no defined palliative care guidelines for Parkinson's globally. And one of my task force's aims will be to actually at least start a framework of that. We need to consider that Parkinson's is not a fatal condition. There's no fatal symptoms. Advanced Parkinson's is often characterised by a high level of disability, unpredictable motor fluctuations. Again, we need that multidisciplinary approach. And end of life is sort of often brought about by an intercurrent illness, most commonly a pneumonia. As we know, we can treat pneumonias really effectively with lots of antibiotic therapy, but we might need to work with someone to develop an advanced care plan to when do we not treat? When do we give, sort of not admit to hospital and give IV antibiotic? When do we not go to the ICU unit? When do we maybe try just orals? There'll be a whole variant of that response, which we need to document well. If we are getting to those advanced needs, the worst thing we can do is think, oh, let's cross off all those meds. They're on so many tablets. Let's cross them all off. That's the worst thing we can do. Seek specialist advice before we rationalise medication. We often can rationalise, but get some advice first of all. Probably the last tablet we're going to be crossing off is going to be things such as that dopamine replacement therapy, which we're still going to need to be getting on time every time. And even if we think that, oh yes, we referred to palliative care, they've seen the patient, palliative care tends to be oncology focused. So they might not have that much of a movement disorder background. Just to finish up with just a brief clip to show that nothing is impossible, but also illustrating the difference between on and off. This fella's off, and he really doesn't look like he's got much movement. When we see him being transferred out to try and take a couple of steps by a couple of physios, what we're seeing is not much movement at all. Weight bearing just, lots of instructions to take a step, but it's not dramatic movement that we're seeing. But when he's on, same day, cycling around, did find cycling was a bit easier, got a bit of a wonky wheel there, need some oil, but that's the difference between on and off. So that's all I've got to say. I think we've run out of time because we had a few IT problems starting up with. Thank you for persisting with my squeaky voice. I'm sounding like a teenager again. Did we have any questions, Andrea?
Look, surprisingly not, but I am a bit worried that that's a technical thing. But by all means, throw in some questions now just as we are finishing off. And I guess I would also remind people to come to the Parkinson's Victoria website, use the phone line, be in contact for further support, advice, some of the things that Victor talked about, the information sheets for particular diseases. They're all available through Parkinson's Victoria. This is all part of your handout pack as well that came out to everybody with a copy of the slides. So like all our programs, they don't finish just with hearing the presentation. It's you taking it back to your work setting, putting it into practice and following up with anything further that you require after today's program. So thank you, Victor, for your time today. Thank you everyone for persevering with our technical challenges at the start. And we just encourage you to continue the conversation so that you're able to provide the best care and support for your people that are living with Parkinson's. Thank you.
And have a happy and safe festive period, and hope you all get a bit of a break.
Absolutely. Thank you, everyone, and thank you, Victor.